Welcome to the Feels Club and Anew Therapy podcast. My name is Mauricio Laguan, and I am your host. Today, I'm joined by Dr. Taylor Brady, one of our providers at Anew Therapy. Dr. Brady is a psychiatrist who works at Anew Therapy, a lot of our patients, to talk about mental health and provide care. I'm really excited for today's topic, which is all about trauma. What is it? How to figure it out if you have it, and how treatments at Anew Therapy can help with your trauma. It's a heavy topic. Trauma can come with a lot. So just be warned that some of our conversations as you go through this podcast might feel a little heavier, but definitely science informed and helpful to you or to anyone that might need the help. Dr. Brady, welcome.
Thanks.
Yeah, it's so good to have you. Welcome to the Feels Club.
I appreciate it. Thank you.
Yeah. As you heard, we're talking about trauma today.
Yeah.
Which can be a pretty heavy subject for folks.
It is.
And it's honestly, as I was thinking about the subject, trauma's thrown out quite a bit. Like even as I was reflecting conversations that I've had with friends and family, like you just hear people. You hear it on social media, you hear it from influencers on TV. People just say trauma. Like I've been through trauma. But you are an expert in this field, at least in psychiatry. So like, can you tell us from a psychiatric standpoint, what is trauma? How would you explain it?
Yeah, I think there's definitely trauma as a buzzword, right? And it's pretty common for even patients to say, well, my trauma is, or I have a little bit of PTSD about X, Y, and Z that's happened in their life. I think about trauma in a couple of different ways, or from the framework of the things that are really important. The event of trauma is really important, but I think the bigger aspect of it is what happens after the event. You know, a lot of us have experienced really challenging and difficult things in our lives, but trauma is really informed by the way that the person that has the experience sort of integrates the trauma into their life. And a lot of times, one analogy that I like to use is a wound, and trauma actually comes from the Greek word for wound.
Okay.
And I talk a lot about trauma as something that may start as a wound and can be something that's bleeding, that's very painful, but it can become a scar. And we've all got scars, and we notice our scars, and in the same way, we never forget our traumatic events. We never forget the subsequent things that happen as a result of our trauma, or the way that we interact with the world, and the way that we, can struggle pretty significantly. But there is a way to make that wound that's sort of open and bleeding become a scar.
Yeah.
So we'll never forget that it's there, but it won't hurt us anymore.
That's part of the healing our trauma,
Absolutely.
right?
Absolutely.
And I want to get into that. I'm hearing from you that there's stressful experiences that we all go through. Could you help us understand what might be the difference between a stressful experience and a traumatic experience? Because I think those can often get conflated.
Yeah. So there's sort of a by the book definition, which is when we're talking about like PTSD, post-traumatic stress disorder, there's a specific criteria that needs to be met for someone in order for someone to be diagnosed with PTSD. And so that essentially is life-threatening events, threats or actual sexual assault, physical assault, violence, things like that. Those things can become traumatic. I think that we would all say that those events themselves can be traumatic, but it's really about the way that the person goes through them and what happens afterward, like I alluded to before, about whether that becomes something that ends up with a diagnosis of post-traumatic stress disorder. And the timing and the integration of those events with our emotions and with our sort of more long-term response is what makes it create the entity of PTSD within a person. But as far as like a stressful thing versus a traumatic thing, I like to think about that with exercise. So my undergrad degree was in exercise, and so I love talking about exercise because
Sure.
I think it's such a good comparator. But if you think about going to work out, we're putting our body through stress,
Yeah.
right?
Right.
And the majority of time, that stress is actually really valuable, right? And in a lot of ways, the stress that we experience day to day, and I'd even say the anxiety that we experience day to day, is very valuable. It's a tool that is super useful for us to grow and progress as human beings. In the same way that if I do, a certain workout, that I'm going to get more effective at that. It's going to make me feel better. I'm going to be more healthy. Now, if I go try to run a marathon every day, right, and don't take a day off,
Sure.
then, could that become an unhealthy level of stress, right? Or am I going to, tear my ACL and that's an injury? And that's the way I sort of think about a traumatic event. Like, it requires a significantly increased amount of recovery.
Yeah.
Even with traumatic events that don't progress to PTSD, there's another diagnosis in the DSM that is acute stress disorder. So it's a more general set of symptoms, but similar to PTSD. And the key to that though is that it occurs within the first month after the traumatic event, which is unique from PTSD, where it occurs after the first month ends. Okay, so it's a persistence of those symptoms over time. So
Interesting.
and yeah, and I think a really important thing to recognize is that acute stress disorder often occurs and doesn't progress to PTSD.
Yeah.
Right.
Yeah.
In the same way that someone might really injure themselves working out, and then they take a few weeks off, and then they're able to get back into it. But in some of those cases, it becomes this lingering issue that really impairs their function over time.
So many gems from what you just shared. One of the things that came to my mind was I often hear from friends and online people talk about like traumatic experiences in their childhood. And what I'm understanding from your definition is, to some extent, a traumatic experience can become PTSD. And I think it might happen in childhood often because as children, we don't really have that repeated exposure, right? Like we haven't worked out a lot. And so because we're new to life, right? And maybe that's why a lot of those experiences from childhood, or a lot of traumatic experiences that some people have, might stem from childhood because of that lack of experience with stressful situations. I don't know. There was a connection there that I made around, as I was hearing you speak with this exercise analogy, that it's like, oh, well, that kind of makes sense. But what I'm also hearing from you is that it's actually helpful to have a certain level of it builds resilience. Like,
Absolutely.
Like of that, like things shouldn't be rainbows and butterflies all the time, and they can't be. Life isn't that way.
Right.
And that exposure is what leads to resiliency, which leads to having a potential traumatic experience and being able to navigate it without causing PTSD or acute
stress disorder. Yeah. So I like what you brought up about kids. In my experience, the people because I only see adults, right? And in residency, we saw kids a little bit, but I only work with adults. And so I very frequently see adults who went through, we call it adverse childhood events or adverse childhood experiences, ACEs. One of the things that really jumps out in what you said is that in a lot of those cases, I would say most of those cases, there is repeated trauma over time. And I would imagine, and I don't know the science of this to back this up, but I would think that a child going through a singular traumatic experience might actually be more effective at overcoming that individual experience than an adult is.
Oh, really?
And a lot of it has to do with neuroplasticity, right? The way that a child's brain is able to adapt, right? And this is definitely not always the case. This would definitely be a generalization. But I think that the people that I see as adults who had trauma as kids very commonly had cumulative trauma over years.
Mm.
And I think about the patients that I saw today, they had cumulative trauma. I can't think of a lot of patients that I've seen who, there's a few, but like this one huge event that occurred in their life. And to me, it's much more common, and probably because if someone experiences trauma, the likelihood is they're going to experience trauma again. The traumatic event and the resulting symptoms from that actually lead to repeated instances of trauma. Like it's more likely to happen, not just because of the environment that they are in, but they're more likely to put themselves in an environment.
Interesting.
Yeah. There's definitely like this tendency to there's like a tendency to be thrill seeking. There's a tendency to put ourselves to be very impulsive in our actions.
People who have gone through traumatic
experiences. In a lot of cases, right? There's a tendency, there's a huge tendency for substance abuse.
Mm.
And so those kinds of things, can lead to a lot of re-traumatization and trauma in different ways
For sure.
that makes things even more challenging, and things get really wound up together.
That's interesting.
And really tied together.
Yeah.
Sometimes I'll ask somebody what their most significant traumatic event that they've experienced is, and they will not be able to choose.
There's just so many.
There's just so much. And often it's the most recent thing,
Mm.
even though the most recent thing might not have been the most significant trauma,
Sure.
right? They might have gone through a breakup recently.
Mm.
And so that relationship ending from a recency perspective, right, is close to their mind. And it might be the thing that is most bothersome.
Yeah.
But they've got this really significant traumatic event from earlier in their life.
It makes me think of what you shared at the beginning around the scar, right? Like you talked about one scar, but if there are multiple scars, right? And then there's not enough time to heal those scars and something comes and ruptures the skin again, then it opens up the wound again.
Absolutely.
So that like repeated exposure that you're talking about, but also the recency, right? Like it could have been a really big thing before and something small happened recently that just reopens certain wounds.
Yeah, absolutely.
In folks, which makes me think of, I'm guilty of using this term, but little T trauma and big T trauma.
Yeah.
Sometimes when I speak about some of my experiences in life, whether from childhood or past relationships or whatever, I'm like, oh, that's not trauma. That's like little T trauma is what I'll tell people to like kind of signal to someone that like, it's not something that is holding a lot of weight on me, but it's clearly something that's remarkable enough that it might help explain my behavior or my point of view or whatever. How do you see little T trauma and big T trauma? Like, is there a difference from a medical standpoint, or is that just more buzzwords again?
Yeah. So there's a clinical diagnosis of post-traumatic stress disorder. And then there's another diagnosis that gets thrown around quite a bit, which is complex PTSD or CPTSD, which is not in the DSM. It's on the Diagnostics and Statistics Manual, but is an idea that there's more cumulative low-level or little T trauma that happens over time that causes us to be on edge, on guard. And I think it might be important to sort of run through some of the symptoms of PTSD that people experience. So PTSD is defined by the specific trauma that occurs, and it has to fit that specific definition. But then there's four main categories, which are reliving the experiences. So those are nightmares, flashbacks, dissociation related to the trauma, avoidance, which is a huge one. And there's the number of ways that we can avoid is probably as vast as the number of ways that we can experience trauma. There's cognitive and mood effects, and there's also arousability. So like hypervigilance and being on guard all the time. A caveat to the DSM is when psychiatrists have looked at the clusters of symptoms in order to name diagnoses.
Sure.
We approach diagnosis in a very binary way, in the sense that a given person either has the condition or they don't. And it's too complex to me, it's too complex to actually do that. If you have a high blood pressure and you go to your doctor and they measure your blood pressure, well, it's either over the limit or it's under the limit, right? And they can figure out how to treat it, but diagnosis with those kinds of things is a lot more simple. But with something like PTSD and, depression, ADHD, anxiety, OCD, any other psychiatric.
It can be a spectrum.
Yeah, it's totally a spectrum.
Yeah.
And so I frequently don't diagnose formal PTSD, but talk about trauma response as being a big component in the makeup of an individual's presentation. Mm. And I think it would be short-sighted to not address it if I think that it's something that's really contributing to the trouble they're having, right? The other thing I think is really important, and I'm sort of getting off your topic about big T and little t trauma, but something else I think is really important is that, yes, diagnosis is important, but it's not as important as helping you feel better, right? And fortunately, there is a lot of overlap in the symptom clusters of these different conditions that people experience, but there's also a lot of overlap in our treatment, right? Which is really beneficial. Like if I get somebody into therapy, for the most part, regardless of what their condition is, that can be beneficial to them, right?
Whether it's like just anxiety or just depression, but might be coupled with some PTSD.
And there's different types of therapies for different types of presentations and different conditions, but just having the person come see me can be beneficial, which is one of the things that I love about psychiatry. Yeah. Right. Yeah. That's kind of off topic of your.
No, I mean, it is, but I really like it because I think diagnosing is important, right? It's an important step in finding the right care and taking a step towards healing, taking a step towards thriving. But taking the steps is what's most important, and treating what is happening with enough information, right? A person should be treated for it to help them getting to that path of healing. I think the providers that I have enjoyed working with the most are ones who use diagnosis to help, but don't hone on it too much. Yeah. They hone in on the healing and what is it that's going to get you to healing? And particularly with mental health, at least in my experience, it's, we can label it so that we can get help. What is it going to take for us to get to that healed version of you?
I think in psychiatry, more than any other specialty in medicine, it's so important to treat the person and not the disease. Mm-hmm.
Can we get back to the little t, big T? What I'm hearing from you on the little t is that it doesn't have to be a big experience, but the little t's kind of lead up to a big T, or they can re-aggravate a big T. Is that a good way to frame the difference between a little t and a big T trauma?
The little t re-aggravating the big T. There's this concept in neurology that has to do mostly with stroke victims. So in a stroke, somebody could lose sensation or feeling or movement on a portion of their body. So sometimes we treat a stroke and all of those symptoms resolve, okay? And they don't have any limitations. Like they don't have any sensory challenges, motor challenges, or anything like that. And there's something called recrudescence, which occurs, sort of analogously occurs in psychiatry, but someone has had a stroke, they don't have any long-term sequela or symptoms of that stroke, but then they end up sick. They get the flu, they get COVID, or they end up in the hospital dealing with something else, and their stroke symptoms come back.
Interesting.
And it's pretty interesting to me that happens because it's just an indication of what that significant level of stress does to that person's brain.
Yeah.
Right? When they're not under stress, they have enough cognitive reserve to sort of cope.
Right.
Right? But all of a sudden you take that energy away and you give them all this other stress, and all of those symptoms come surging back. And so in the same way, someone has early childhood trauma and they've gotten through it. This is something that I see pretty regularly as well, is someone has done therapy and has gotten treatment with medications and a lot of their trauma symptoms have resolved. Now they're in a situation where they're going through a divorce or they're struggling with their kids leaving home or menopause or, any number of things.
Yeah.
And then they're like, why am I so anxious all of a sudden? Why am I starting to think about all of these old things that have happened to me? Why am I anhedonic? Like I don't want to do anything that I used to enjoy doing, right? And I think of it as this recrudescence, like this new stressor has made all these new old symptoms reemerge.
Yeah.
And so it's like, okay, well, what do we need to do about this? Is there need to be a new treatment? Do we need to re-engage? Do we need to, what else are you doing in your life, or what kind of things can we modify so that we can get you feeling better?
Yeah.
And I the other thing about little T trauma is I think it goes back a little bit to the idea of the integration of the trauma. Sometimes someone will experience something really significant and they'll really struggle for a little bit.
Mm-hmm.
But then they will start to integrate that into their lives in a way that's really healthy and balanced.
Mm.
And a lot of those symptoms will resolve.
Mm-hmm.
Okay. In those cases, I wonder if you think about little T trauma in that way, like it's something that someone was able to integrate.
Yeah.
But then I also think that there's some really, really hard, difficult things that people have gone through that, that you could consider that are not life-threatening or not sexual assaults or not losing, witnessing violence or.
Yeah. And I mean, even hearing you say that, it's also person dependent, right? Like I could think, like, I'm sure siblings can go through a similar environment, right, in their household and be experiencing very similar things and have completely different outcomes. For one, it might be one of those traumatic experiences, and for the other, it might not be. And I find that to be very interesting to kind of like unpack. And I'm sure that, there are other layers to that you would have to unpack, right? Like, is it a denial of the trauma, or is someone more leaning into healing and is the other one just more ignoring it and avoidant? But I do think that there is, or even person to person, like I could have a very similar experience as someone and I might not consider it a traumatic experience.
Yeah.
But someone else might.
Right.
And that's fine, because what I'm hearing from you as well is that healing isn't linear and isn't the same for everyone.
Yeah, absolutely not.
Which it's just an ethos or something that I just like abide by in life, is that like it is not linear. Like something that might not be a problem for the majority of my life, something new happens. A child is born, or the divorce, like any life change could just re-aggravate or even surface things for the first time that you might not have been there before. And that just goes, the healing, particularly around mental health, like it's not linear.
Right.
And it can change through the different stages of life.
Absolutely. It's interesting the idea of like two people going through the same trauma and then having different responses to that. I can't understate how important I think social support is in those situations. I think about two soldiers in the same unit that, had these really traumatic things happen, and they were together the whole time. One of them develops PTSD and one of them doesn't. That idea of integration, I keep referring back to that, but that idea of integrating in a balanced way that traumatic event and sort of internalizing the emotions associated with it and processing those emotions is so incredibly important. And maybe one of those soldiers has someone to process it with, and the other person doesn't. Maybe there's a genetic predisposition to post-traumatic stress disorder. Maybe there's other environmental factors that are contributing to it. Maybe one person has developed resilience through other methods in their life leading up to this, and a myriad of other reasons.
Sure.
Yeah, that's a pretty fascinating idea. But I think, like I said about social support, if you can intervene, right? I have a patient who just recently went through something very traumatic, who has a historical diagnosis of PTSD, went through something pretty traumatic within the last couple of months. Her PTSD symptoms had pretty much resolved. She had like some very minor symptoms and was doing really well. Now this new trauma occurs, very significant. And she can't sleep. She's having nightmares constantly. She can't talk to anybody. And so I sort of went on full alert, like, okay, we're meeting every couple of weeks. I'm contacting your therapist so that you can re-engage with them. We need to reintegrate this new experience, right? And within a month or two, she's she's back on track and, still has some residual things, but she's doing a lot better. We had changed the dosage of her medication, increased the dose to treat some of that as well. I think that in a lot of sense, she's just really lucky to have a way through that. And a lot of people don't.
Yeah.
It's tough.
And I think there's so many social and environmental factors, but I think there's also stigma around some of this stuff too, right? Where people just feel isolated because of that stigma, because you can't talk about it, because I might be the only one going through it. And there's like that internal narrative and that external narrative that sometimes feeds the internal narrative that this isn't something that's solvable. I really appreciate, community is something that's really important to me, and friends, family, colleagues, like the more I've experienced my life and mental health and all of the different things that I have gone through, the more I lean into people, the less isolated I feel, the more help I feel, the more resilient I feel. And it's easier to navigate through some of these things, because oftentimes I find myself saying some stuff and I'm like, oh, I'm actually not alone in this at all. And we're all going through a version of this.
Right.
So what are you doing to, go through it? And can I apply some of those things as well? And then obviously having providers when we need it. And the care. Therapists are great. Psychiatrists are great. They change lives.
We try to be good.
Yeah. Can you tell me a little bit about what is going on the brain when someone is going through a traumatic experience?
Yeah. So I love this topic. And the framework that I sort of think about this through, and that I talk to a lot of my patients about is, maybe we should go through that, because I think it's really, really, I think it's a good way to think about this. So our brain has these different levels of consciousness, right? And we have our like sort of reptilian brain, which is focused on survival. We have our mammalian brain, which is focused more on the emotional aspects of it. Like, your dog can feel emotions, right?
Sure.
And then we have our frontal lobe, which experiences consciousness and self-reflection and humor and all these, sort of advanced,
more complex
things that humans experience. At a subconscious level, our brain is constantly taking in stimulus from the environment. And it makes a determination about whether that stimulus is worthy of our conscious thought or not.
That's so fascinating.
Right?
All on its own.
All on its own. So everything that's happening in your peripheral vision right now, it's going to your brain. Here's the proof. The proof is that you've had that shirt on the whole time we've been sitting here and you haven't thought about it once.
Right.
So the receptors in your skin are stupid. They just send this repeated signal, and then your brain actually suppresses that signal as well. I don't need
to. But if I were uncomfortable in the shirt,
yes,
it would signal to my brain
like, oh, that's a different sensation, and then you'd become consciously aware of it.
Sure.
So our brain is constantly determining whether it's important enough information for us to make it conscious.
This is why we sleep.
Right. So
it's a lot of work.
Now, so put that on pause for a second. So now let's think about evolution and what's most important to our species and not to the individual. Because if you think about it from an evolutionary standpoint, what's important to the individual isn't as important as the species, right? And so at a very core level, our brain's goal is to keep us alive, to procreate, like the fitness of our species. And that's what it does. Like at its core, that's what's most important. And it's also the thing that our brain is best at doing, right? Is keeping us alive. Now, let's say we're cave people, we're living, we're hunter-gatherers or whatever. Something really traumatic happens. We get chased by a bear, okay? We have these sensory inputs, okay, that put us into fight or flight mode. We run away or we fight back. We have emotions associated with that, okay? And then we have thought processes about what that experience means, right?
It moves into that frontal lobe that you were talking about.
And there can be an integration of that experience. Okay, now I need to watch out for bears, right? But there can also be sort of a sustained level of fight or flight, okay? which if things aren't integrated in a, you know, in a balanced enough way or effectively enough, then we are sort of perpetually in fight or flight. Now, if we go back to, you know, our brain taking in all these the stimulus from the environment, now everything is a threat, potentially, right? And so we begin to see bears in the forest that aren't actually bears, right? And out of the corner of our eye, we see something that frightens us, right?
If I'm understanding, those subconscious
Yes.
through lines are the ones that are moving that into the consciousness,
Right.
saying like, you're going to get attacked again,
Mm-hmm.
all because of that consciousness that we created around the actual experience.
Yeah. Because survival is so important. And so anything that is deemed to be unsafe, and the threshold for what's unsafe is a lot lower now, right? We're all of a sudden seeing everything as a threat, right? And so you can see why somebody who's experienced trauma is now hypervigilant.
Yeah.
And they get up in the middle of the night to check that their door's locked, right? Or they can't sit with their back to the door in a restaurant, right? Because they have to see who's coming through the door, right? It's why they have nightmares.
Sure.
There's a theory that nightmares occur in order for our brain to remind us of the threat.
To keep us alive.
Keep us alive.
Yeah. Going back to that survival thing. Like, don't lose this consciousness.
Don't lose this.
Yeah.
You'll die. And the other really hard thing is that and this is a component of PTSD, is avoidance. So we avoid thoughts and emotions and triggers that are associated with our trauma, with our traumatic event that we've experienced. Now, this becomes incredibly problematic because, you know, if I recommend, you know, if I were to go to somebody on the street who's got PTSD and say, I wonder if you should see a psychiatrist, their brain's going to avoid that because I have to revisit those emotions and I have to revisit those thoughts, right?
Yeah.
And so all of a sudden there's an impediment to their improvement because of the avoidance.
Right. Again, tying it back to the survival, like I don't want to remember those things because then I'm going to go back into survival mode, which is going to cause additional stress. So yeah, I'm just going to avoid it.
Right.
And I'm assuming that some of that avoidance isn't just the avoidance of the thing, but avoidance of a lot of things, right? I think you had mentioned one of the symptoms is like also not finding like joy or excitement for things that you used to find excitement for.
Yep.
Like that could also be a form of avoidance, if I'm understanding that correctly.
Well, that's interesting. Is that a form of avoidance? I think that is, you know, that has to do with, I think that has to do more with sort of deep-seated emotions associated with trauma. Something else that I think is important to discuss with regard to the integration of those experiences is primary and secondary emotions, or primary emotions and manufactured emotions. And this sort of comes from a type of therapy called cognitive processing therapy that I trained in residency, and is, you know, I'm partial to it because I have a lot of experience doing it. There are specific emotions associated with the experience of the trauma, right? So a kid going through an abusive situation, there's fear, there's anger, there's sadness. Those are true primary emotions associated with those events. But then what our brain does is it starts to create manufactured emotions to avoid dealing with those primary emotions because they seem too painful. And the ones that I run into the most are guilt and shame.
Wow.
Okay? So people start to blame themselves for the trauma. And, you know, that in turn creates so much discord, right? Because then they continue to feel angry and they have anhedonia, like not interested in doing things, and they present with severe anxiety. And, you know, guilt is one of the criterion for depression. And so now all of a sudden they've got a diagnosis of depression, but underlying it is these traumatic events that have occurred in their past.
You are literally reading my mind because I wanted to ask you, I mean, we've been talking a lot about trauma and in association with a lot of other mental illnesses. It feels like trauma can often be mislabeled. Like it could, to your point, you're exhibiting these symptoms and it could be like, oh, you have depression, but when in reality it might actually be trauma.
Yeah.
Does that happen often? And like, what are some of those markers where like I as an individual can navigate, like, is it trauma or is it OCD? Is it trauma or is it anxiety? Is it trauma or is it?
Yeah. So we think about diagnosis in those clusters of symptoms. And I mean, I think the main thing is there an index trauma? Is there a traumatic event that led to the onset of these symptoms? Right. And there are specific things that are unique. There, within each of those symptom clusters, there are things that are sort of unique to each one.
Sure.
But there is a ton of overlap, which makes it diagnostically challenging. But like I said before, the main thing is to help somebody feel better. It's our job as psychiatrists to sort of wade through the myriad of things that people are experiencing and try to parse out what can be most effective for treatment for them, for that individual. And not to think of it, the cluster of symptoms for a diagnosis is more of a systemic social level of understanding of the way that those conditions work. But that the thing that's really important is the person in front of you, right? And helping them to feel better, regardless of what the overlap is and what their symptoms are, and really taking into account whether they've had trauma and trying to figure out how much it's truly affecting them versus maybe something else in their lives.
Yeah. Can we talk about some of those overlaps, like what that might look like?
Yeah. So the one that I run into constantly, especially nowadays, is ADHD.
Tell me more.
ADHD, trauma is a buzzword, so is ADHD.
Sure,
right?
yeah.
So I have a lot of people that come to me and say they think they have ADHD, or they're 100% sure they've got ADHD. I looked at what the
internet
they looked
says.
it up on on
WebMD,
TikTok or whatever, and they figured out what ADHD is. And it's true that they might be dealing with those symptoms. Like they can't focus. They're easily distracted. They're really struggling to stay on task. They can't get their work done. Right. And very, very commonly, I ask them about their history with trauma, and they've got significant onset of symptoms after something significant happened in their lives. And I the way that I conceptualize this, and it sort of alludes back to what we were talking about the way that our brain is functioning on high alert all the time after that trauma. So we're on high alert, and the brain is literally using up metabolic energy, right? It's usually literally metabolizing our blood sugar in order to make us consciously aware of potential threat, right? And now all of a sudden, it's not surprising that there's not enough energy left over to stay focused and to stay engaged in those things. And I think that is definitely an oversimplification, but I really like that sort of framework. It doesn't mean that somebody doesn't have ADHD. Sure. In fact, a child that has experienced trauma is more likely to develop ADHD. And more likely to experience depression, more likely to experience drug abuse and alcohol abuse.
Kind of be one of my questions, like if the coupling of these diagnoses are more commonly seen, like, right, like you see a lot of anxiety with depression, like is PTSD or trauma usually coupled with some of these other diagnoses as well? And then what I'm hearing is that there is more and more correlation between, or at least in your experience or what people are saying, I have ADHD, but actually it might be trauma or it might be a combination of both. Do you see that with other mental illnesses as well? Yeah,
absolutely. I see people presenting with depression. I see people presenting with a lot of anxiety from their trauma. PTSD used to be an anxiety disorder in the older versions of DSM. It's not anymore. It's in a new section called the trauma and stressor related disorders. It used to be considered an anxiety disorder because that was such a prominent aspect of it.
Sure.
But yeah, there's a lot of overlap, and I see a lot of those things comorbid with each other.
There's so much that we can talk about when trauma, and I appreciate, and I hope this isn't the last time we talk about not just trauma, but the only time we talk, because I think there's so much to unpack around even other mental illnesses. But I want to talk about like things that help. how to treat trauma and traumatic experiences.
Mm-hmm.
You've talked about it, right? You've talked about your patient experiences, like what you've seen, therapy, medication. What are some of those general things that you're like 1, 2, 3s of like how to get help and what helps?
Yeah. So therapy is at the top of the list. And there's a few different types of therapy that are specifically geared towards trauma. One of the great injustice of trauma to me is that trauma is very, very rarely the fault of the person who is traumatized, but it becomes their responsibility.
That is an injustice.
Right? Like they have to be the one to work through it.
Mm.
And it's incredibly challenging. And I often say that there's no way around it. You have to go through it. Now, that doesn't mean that I have to go relive my trauma.
Sure.
Right. But, through different types of therapy, like CPT, like we've talked about, EMDR, trauma-focused cognitive behavioral therapy, there's a certain element of acknowledging and integrating, like I've talked about, like integrating those emotions that are still there. And it's like they're like a tea kettle that's ready to explode, right? And every time we avoid, right, we're sort of suppressing it even more. And it starts to like have these little like sparks that are flying out, right?
You increase the pressure.
Increasing the pressure. And so, our spouse says something and we fly off the handle for no reason, right? Or we're in traffic and someone cuts us off, right? And we completely lose it because we are trying so hard to keep a lid on all of this. So like hitting the release valve, right, can be so valuable. But, and those different types of therapy have different modalities, but it's all about integration of those emotions.
Sure.
And integration of the way things are working in someone's brain. And, I don't like to, there used to be this idea that going through, like reliving our traumatic events was the way through it.
Sure.
And most therapies don't do that anymore.
Yeah.
They think it's more important to focus on the emotions and processing what those emotions are than actually going through and describing in great detail every single thing that happened. In fact, in cognitive processing therapy, you go through this, it's a very stepwise algorithmic approach to therapy. And at some point there's a sort of a decision point where you ask the person if they want to write about their trauma, right? And for some people, they find that incredibly therapeutic. For other people, they don't want to do that at all. But the outcomes from the therapy are the same, right? So I'm really cautious about saying, okay, you don't need to like relive every moment of this horrific thing that happened to you.
Sure.
But there's going to be some hard things that we have to face, which goes back to that being such, the great injustice of trauma.
You've used the word integration basically from the onset of our conversation, which feels like, I understand the word integration, but it feels like it might have a deeper meaning for you as a physician that maybe I'm missing. But in or even in therapy, like what I'm understanding of integration is instead of avoiding or ignoring the emotions attached to the traumatic experience, the integration is understanding how those experiences have caused the emotional responses and allowing those emotional responses or creating consciousness around those emotional responses to choose to behave differently or to integrate those behaviors in a healthier way into your life. That's how I'm understanding integration. Would you say that's accurate?
That's how I think about it as well. I think about the CBT triangle, which is the idea of thoughts and emotions and behaviors and the way that all those things are integrated together and how they all work together and affect each other. Now, if we've got these emotions that are so incredibly challenging that they, immediately affect our behavior, right? So getting cut off in traffic, right? And we jump to whatever the behavior of yelling or whatever we do so quickly, right? And this doesn't just apply to PTSD and trauma, of course, but a lot of different things. But if there's trauma that has led to those sorts of emotions and those sort of behavioral responses as a result of the emotions, then is there a different choice, right? Can I make a different choice?
Sure.
And I think that a lot of it is about finding the space between the emotion and the behavior. Can I give myself an instant of reconsideration? Right? So it doesn't just become an automatic behavior. Right. And I think when somebody, these two people that experience the same trauma and one of them sort of integrates that and the other one doesn't, maybe the person that's integrating it has this previous resilience built up and they've been able to sort of process it on their own. Or maybe they are someone who journals, right? Or maybe they have someone to talk to, right? But then the other person might be more isolated and they struggle to really process what those emotions are. And so then we later on go back and talk through that in a way that allows that integration to happen in a much healthier way so that we can change that immediate response when we have those negative emotions or those stressful things happen.
Curious, what role does medication play in that process that we just described, right? I'm assuming there's probably an array of medications that can be used as treatment to help with PTSD or processing traumatic experiences, but what the typical ones that you prescribe and what are they doing to help a person overcome?
The main medications we use are antidepressants and specifically SSRIs and SNRIs. I think about those medications, those medications can resolve a lot of PTSD symptoms, but I think of them more as helpers than I do as things that cure PTSD. Okay. From some standpoint, if someone has the cluster of symptoms of PTSD and those symptoms all resolve or are decreased, then they might not have a diagnosis of PTSD anymore, but have they resolved that trauma, right? Have they resolved and reintegrated that traumatic experience? One of the things that is really wonderful about our medications is that they increase the amount of neuroplasticity in the brain. So our brain's ability to make new connections, new synapses develop, and our neurons have these little feelers that go out called dendritic spines and dendrites, and they touch other neurons and they create these new connections. And so antidepressants help facilitate that. So that's sort of what's happening when you have these revelatory moments, like all these, all of a sudden these things connect, right? Medications can be extremely helpful, especially for people who are processing their trauma through therapy. But they can also be really helpful for those individuals who don't want to do therapy. And there are a lot of those individuals. And so if somebody says, I just don't feel like I can do that, then okay, well, let's try medications if that's the route that you want to go. And, I'm still going to keep encouraging therapy because I believe so strongly in that. But let's see if we can help your symptoms.
As you know, at Anew Therapy, we like to be on the cutting edge of new technology, new medications, new science-informed treatments. One of them being ketamine-assisted therapy, which we've talked about in previous episodes. What role does ketamine-assisted therapy have? I'm assuming it's pretty similar to what you're describing with SSRIs.
So ketamine's pretty different in the way that it works from SSRIs, but ketamine-assisted psychotherapy, I'm not actually sure on the latest data for ketamine-assisted psychotherapy, but for ketamine specifically, it's been more and more studied recently, and it has shown a lot of promise in treating PTSD symptoms specifically. And so, I think that the therapeutic aspect of it, there are some cautious approaches that we should probably take with ketamine, because some people with PTSD tend to dissociate. And ketamine is a dissociative anesthetic. Like that's what kind of medication it is.
Yeah.
And so we do have to be really cautious because we don't want to worsen those types of symptoms. But I definitely think there's, we're going to get to a point where there's a really profound role for ketamine in treatment of PTSD. I don't know that we're quite there.
Yeah.
But with so much comorbidity with PTSD and anxiety and depression and other psychiatric illnesses, like you can definitely treat both of them at the same time.
Yeah.
And so, it might be something to explore.
That's really cool.
Yeah.
Thank you so much for,
of course,
it's just literally the myriad of things that I've learned and taken away from our conversation. Before I let you go, we asked friends, colleagues, just random people, like FAQs, like what would you want to know? So I have some rapid fire questions. Can we go through them before we go through the end? So again, we might want to go deep, but if you could give us a quick response to these rapid fire ones. Can trauma come from childhood even if you can't remember details clearly?
Yes. Yep. And it's common to run into people who have no memory of their childhood. And I wouldn't say common, it happens. And that makes my feelers go up. It makes me think that there was something happening.
Yeah. Wow. What is an emotional flashback and how does it differ from a memory?
An emotional flashback. So I don't think I've heard the term emotional flashback. Sure. A flashback is a re-experiencing of our trauma, of our traumatic event.
Which can be different from a memory, right? Like going back to the first question, like you might not remember the details or have a specific memory. You might have the emotional reaction that might be similar to the traumatic experience that you went through.
And I think one of the big keys is that flashbacks are distressing, right? And they're distressing at an impairing level, right? So I'm working on something and all of a sudden I may have a flashback and I can't remember what I was doing. I'm taken out of the moment. I might dissociate. I might have a visceral response. My heart rate goes up. My blood pressure goes up. I start sweating.
Yeah.
I get dizzy and tunnel vision, right? So it's impairing, and which is, we all have bad memories, right? But I think that's the big difference.
Why do I overreact to small things when I know I'm safe?
Because your brain doesn't think you're safe.
That goes back to the survival. Is it normal to feel numb instead of emotional?
Is it normal to feel numb instead of emotional? I wouldn't say that numbness is normal. I think typically if somebody feels like chronically numb, there's a reason for that.
And I'm assuming here with this one, it's like, maybe I'm not crying all the time or angry all the time, but maybe I just feel a sense of like just numbness. Either situation you'd want to address.
Yeah,
what's going on.
I think, there's a spectrum, right? So everyone has a spectrum of emotionality, I guess. Some people experience really big emotions and some people, their emotional spectrum is more narrow. But if someone feels numb to the point that it bothers them, then I think that that's something that could be addressed. And that's something that's common in trauma.
Can trauma be healed or is it just something you learn to manage? That's a deep one.
That is a deep one. I think both, right? I see a lot of people who have had very significant traumatic events, resulting traumatic symptoms, who are functioning fairly okay in their lives.
Yeah.
Holding jobs, raising their children. They might be in distress quite frequently and struggling, but they're managing.
Yeah.
Right? Yeah. Does that answer your question?
It does.
Okay.
It does.
Yeah.
How do I know if I should seek trauma therapy versus just general therapy? Or is it the same?
Yeah, I think getting evaluated is really important. And no, they're not the same. And I think, getting an evaluation from a psychiatrist or a psychiatric professional is the place to start. Having a sort of exploration into how much the symptoms resulting from the trauma are bothering you versus other psychiatric things or things that you're dealing with in life, and go from there.
What are 2 to 3 grounding skills people can try when they feel activated in the moment?
Yeah, there's a couple that I really like. One of them is the ice pack. I love recommending that someone have an ice pack in their freezer that they have easy access to. And I have them like put it on their bare skin, like the back of their neck.
Okay.
An ice pack is like kind of painful,
Yeah.
right?
Yeah.
It doesn't feel great, but it really brings you back into the present moment, right? And sort of dissociating or being outside of the moment, the grounding techniques that sort of bring us rushing back into the present moment can be really effective. Another one that I really like is the 5 senses. Like, what do I see, hear, taste, touch, and smell right now? And going through that process can be really grounding as well. I also love like sort of visualization practices where you put your feet flat on the floor and you sort of visualize roots growing out of the bottom of your feet and encircling the center of the earth. That's something that I like to do.
It's really cool.
And doing some deep breathing, box breathing, where we breathe, same amount of time in as the same amount of time out. Those are a few that I really like.
What if someone that's listening to us talk is like, maybe this is me, maybe this is someone I love or someone I care for? What should they do?
I think that there's like that tendency to avoid, right? And so there's an initial sort of wall up that needs to be overcome. But if you're able to push through that and make that first initial phone call to, if it's your general practitioner or a therapist, someone in the community, like getting in for that first appointment can be very valuable.
Absolutely.
And having a lot of your feelings and your emotions validated, which is something a lot of people with trauma haven't experienced, like can be pretty eye-opening and give a lot of hope to those people. Yeah.
And I would be remiss to not add, reach out to Anew Therapy, anewtherapyutah.com. There's a phone number that people can text or call. And what we pride ourselves at Anew is that we can meet psychiatrists like yourself. We have therapists in-house. We can do medication management with SSRIs and do cool stuff like TMS, ketamine-assisted therapy. Yeah. There's a myriad of options that you can tap into by coming to Anew. So I hear you loud and clear. It's about calling and reaching help, even if the instinct is to just stay quiet or keep it to yourself.
Absolutely.
Again, thank you. That was my last one.
Okay.
To our listeners and our viewers, if you or someone you know could find this podcast helpful, share it with them. Subscribe to the Feels Club. Dr. Brady, thank you.
Thanks, Mo.
for everything. Appreciate it.
Good to be here.
Yeah.
Thanks.